what is the governance challenge that we are facing as practitioners, as people who work on research in the sector? Now, the first assumption, of course, is that we have far less of an understanding of what will work ex ante in a fragile context. We really have we have very little understanding or limited understanding of what is happening in developing country context because of the particular political economy of the transition they're going through. But certainly more so in fragile contexts, we have very little idea of what's going on. And the reason why we are also emphasizing on using horizontal networks in our framework is largely this: more so in fragile contexts, in context of weaker rule of law, you actually have a lot of informal horizontal networks being used for enforcement, far more than the vertical formal top-down hierarchy of formal institutional enforcement. So we actually thought one good way of making something feasible and having some chance of impact is to also start working with these informal horizontal networks. Of course, the formal mechanisms of state are definitely going to be a part of it. And we already know that as the pandemic has started to unfold, procurement and relief distribution processes are the most susceptible to corruption and leakages and inefficiencies. And this is not just in developing countries. I mean, we've had questions being raised about procurement processes right here in the United Kingdom. So when you're talking in the context of a fragile state where enforcement mechanisms are already weak, something like a pandemic and the demands on procurement and other kinds of efficient responses that are made on these formal mechanisms are actually under even more stress. And the other political economy aspect of fragile states is, of course, that there are some deeply embedded patronage and patron-client networks who in good times tend to corral all your contracts. And at these times, especially because of their higher relative power, tend to actually get the lion's share of most of the contracts, procurement contracts, or any kind of delivery mechanism that might give you an opportunity or give them an opportunity for rent capture. So that's the very adverse context. And being a good political economist, I've set it up in the most pessimistic manner possible. And you might be wondering, well, then what is the way out of this? And exactly because of the context that I just laid out, the scaling, the adaptive, and the sort of iterative framework that we've set out, we think is one way out of this adverse context that I've just described to you. Teresa, could we have the next slide, please? Right, now, how can scaling possibly help us with this particular governance challenge that we're talking about? Now, governance and corruption related constraints actually hinder scaling up. And that's largely because if you go via only the formal mechanism, the formal institutions, donors tend to go through the formal institutions far more, they're actually not set up to respond during an emergency like this. At the best of times, they have capacity constraints. At these kinds of critical times where you need a response that saves the maximum number of lives with unfortunately, the minimum of resources, that sort of setup is absolutely not geared to scale up very quickly and deliver. So an innovative anti-corruption approach, which involves mobilizing multiple providers for each delivery goal and delivery component of the treatment system, and not just relying on the public health system, is what we are talking about. That's why we think it's innovative. It's the fact that we are talking about mobilizing. It's the fact that we are talking about simultaneously mobilizing and scaling up what works and what doesn't work, and essentially building in a lot of redundancy. And I'm going to try and unpack all of this as we go along over the next few minutes. And in terms of the incentives behind why this might work, because at other times we see that the incentive for making something like this, which might sound a little complex, work, don't seem to exist. But the incentive here really could be the fact that we are in a national emergency, and that can actually provide the framework for cooperation that you need to achieve these kinds of rapid results. So that's the combination that we're really looking at. Achieving cost effectiveness while focusing on building redundancy. Now that's interesting. Some of you might already be wondering what it is that we are talking about here. But this is something, the cost effectiveness is actually because we are building in redundancy. And I'll be talking to that a little more later. Teresa, could we please have the next slide? Yes, yeah, if we can have all the figures. Thank you so much. So this was a paper that we wrote early on in March when lockdowns were pretty much the order of the day. And we know that lockdowns are not so much part of the policy mix, but the lockdowns have actually become now for us a proxy of social behavior and the sort of social discipline that's required to counter a pandemic of this sort. The lockdown and what kind of lockdown strategy you have, or let's say, social disciplining, I won't use the word lockdown, the social disciplining or the behavioral response that you might have is very, very connected to the kind of treatment response or health strategy you might have. But both of these are extremely dependent on the governance constraints. And that's something that we tend to forget about. What are the governance constraints? They're not just the technical governance constraints, they're actually the political economy constraints of any kind of developing context, and certainly in a fragile state context, or even if you're talking in a relief camp. In the typical developing country, at the best of times, you will have absenteeism as a huge problem among primary healthcare centers. You will have primary healthcare centers, but they exist in brick and mortar. So at a time like this, your social behavior, your social disciplining strategy, how that's linked to your health strategy is seriously dependent on what your governance constraints are. And unless we think of these as a kind of continuum, interdependent continuum, we're not going to be able to get to the best kind of policy that you can use to respond to this kind of a pandemic. So Teresa, next slide, and then I can explain this a little more. Thank you. So what are the two components of a health strategy essentially? And first, of course, is that the behavioral response. That is, what is required for me to do? What does it mean in terms of enforcing social discipline? That's fairly obvious. And the treatment response is also fairly obvious, which is how do I use testing? How do I use tracing and quarantining? All of that is essentially part of the treatment response that we're talking about here. This pandemic, and this goes for pandemics, across time. Pandemics actually impose externalities on society. And therefore they require a sense of social discipline. And when I mean they impose an externality on society, what do I mean? It basically means that there is a trade-off between private cost and social benefit. I might be young. I might not want to stay at home. I might want to go out because I know my risk levels are low. But if I'm out, there is somebody in another demographic who has to stay home. That's a very, very clear, obvious trade-off. There are also trade-offs based on the economic context that we talk about. So that becomes a huge issue to deal with. And even the most advanced country in the West, societies, politicians are finding it very difficult to tamp down in those kinds of societies. So social discipline is a problem even there. We just have a few East Asian countries which are outliers and have been able to impose some kind of social discipline, largely because they've had experience with pandemics before, whether it's been SARS or whether it's been the swine flu. But across the board in developed and developing economies, imposing that kind of social discipline is very difficult. Doing that in a fragile context where legitimacy is a question becomes even more difficult. And for very obvious reasons, the capacity for a high functioning treatment response is also low. And we're just not talking about in medical terms, we're actually talking about in terms of long-term economic and organizational capabilities. That just does not exist. And that becomes another critical issue. Next slide, please. Right. Now, how does all of this actually link to scaling up? Now, both behavioral response as well as a treatment response certainly have long-term determinants. There are historical power structures, there are historical capabilities building up. It's not something that has been built up overnight. But then for sure, these are actually variables that can be addressed with some short-term mechanisms. And that's what we are talking about pretty much here. What do I mean by these short-term mechanisms? And that's actually, if you think about it, health systems in most developing countries, in most fragile contexts, are for very good reason because their finance is very tightly controlled, is either donor driven from the top or from the Ministry of Finance or driven by the Ministry of Health, which then goes right down to the public health system, to the primary healthcare system. But all of that is very hierarchical, very top down, with the technical constraints as well as the political economy constraints that we are talking about. If within the context of these constraints, you ask such a system to scale up, That's not going to be possible. So what is the short-term way of ensuring success through scaling? It's by expanding the universe of organizations that you're working with, and by defining treatment components that each of these delivery agencies are actually going to be working with. Now, social discipline can actually be improved in the context of an emergency response using community mobilization. And while Bangladesh has not used it during this pandemic, there have been organizations like BRAC that have actually gone out and tried to do this kind of mobilization. And in general, Bangladesh has been extremely successful with its public health response using community mobilization. One of the best examples, I'm sure all of you are very aware of it. But even in the context of very high levels of corruption and patron-client networks, it's actually possible to use multiple delivery networks. And this is something that we've actually managed to locate through some of our research in Uganda. We have a very a sort of innovative healthcare pillar in the ACE research, and Uganda is one of the countries that our partners, the London School of Hygiene and Tropical Medicine, are working in. And what's actually come to light is, even though the government has not licensed them yet, Uganda has a fair number of trained personnel who actually run or work in private drugstores, trained healthcare personnel who work and run private drugstores that the government has actually not come to recognize. But there is a high level of expertise there. And if the difference is a primary healthcare center which is shut and a private drug seller which has expertise, you can go to that person, and she can be the first line of response for you in the context of, let's say, home care settings in the response to treating COVID-19. That can actually become a very successful delivery mechanism when the public health system isn't delivering. So it is possible to look for the widest possible, relevant, widest possible network, and then come up with the kind of organizations that actually would be able to deliver. So we are implementing adaptive approaches of scale by joining up different organizations of different capacities, which are actually delivering different components of the healthcare system. And it's important to note that the reason why we're proposing this is that each provider has different strengths and weaknesses, and each of these can then be used to scale up and scale down. And that's the simultaneity issue that we are talking about. So of course, it needs a huge coordination mechanism behind it, but in fragile contexts, you also have donors, you have large NGOs. So it is actually possible to have a fairly robust coordination mechanism behind this. So you actually recognize the various strengths and weaknesses of these multiple delivery organizations and scale up or down simultaneously as is a requirement. Now, this is not something that will get rid of corruption. And at ACE, we tend to be very realistic about what kind of corruption we can address and how much of it we can address. And indeed, getting rid of all corruption in the procurement process should not be a priority during a pandemic response. The priority should be saving lives, using the least amount of resources in the best possible manner. Now, I know this sounds suspiciously like optimization, but this is really not the optimization strategy that we see in basically the kind of conventional economics textbooks. And that's largely because an optimization strategy requires for us to know the costs and benefits of each options. And in the context that we've just described of fragile governance, weak rule of law, we simply don't know all the parameters in those kinds of fragile contexts. And even finding out that information has a transaction cost. We tend to forget that these are not contexts of perfect information, full information, and zero transaction costs. Finding that information has costs, and it's not just technical information. This is really the political economy information of where are the leakages, where is the capture that's taking place. So for us, the fundamental question was, what is the strategy that generates the best information at the lowest transaction cost? Now, the standard sequential scaling up, which is we start small and we pilot up, we simply don't have the time for it. And that standard sequential scaling up, cannot control for changes in conditions over time, and it takes a long time. And in both cases, time is of the essence, given the kind of response that we are looking for. So therefore, our strategy of finding simultaneous channels might seem like we're building in a lot of cost, but that's the redundancy. And in fragile and weak rule of law context, we propose that that's really the best option for the lowest transaction cost approach that can actually generate the most appropriate information for us. Through the built-in redundancy that I am now talking about, we can actually identify what are the interventions that are working, what are the delivery agencies that are working, and start scaling them up. So in that sense, it's not the lean cost effectiveness that we are talking about, but it actually allows us to identify through the creation of deliberately building in redundancies, the kind of delivery agencies and the kind of interventions that are working for us, allows us to scale them up, deliver more effectively, and therefore become more cost effective. May I have the next slide, please? So as I said, the judgment on the mix of health interventions is therefore very, very critical in this ability to scale up fast. If I don't identify what I can scale up with, I'm actually falling short on the kind of interventions that I can provide. Now, it is integrated because we are looking at connecting all the health interventions. Essentially, this has to be an iterative process. It's not a sequential one. And when I mean all the processes, it's not just talking about the medical or the clinical processes. And I'll talk to it in the last slide when we actually propose some of the alternative mechanisms and how these networks might matter. But just to give you a very small example here, it's not just about testing and tracing and going door to door, for instance, using a community network. One possible intervention might be, in certain cases, to impose a kind of small localized lockdown when infections are ripping through a particular community. You might want to then mobilize a local transport agency to deliver either medicines or food in the context of home quarantine. So we're even talking about those kinds of interventions that, if are necessary, will need to be looked at. It is adaptive because some links in the chain might work, networks rather in the chain might work and might not work. But we think this is going to work because a lot of people might say there is a multiplicity. But again, in the kind of context that we are talking about, in fragile context, you have capacity constraints to begin with. So therefore, the number of interventions is in any way finite, and the number of organizations and networks that you're dealing with relevant to the COVID-19 context are also constrained. So therefore, it is a finite universe on both the counts. So it should be possible for us to design this kind of a scalable matrix system. So this is essentially what we're talking about. And important to note that cost effectiveness is achieved because of built-in redundancies. And I think that is something that I also explained in the last slide, but just to go into a little more detail here, the true cost of an extra bed or testing kit is not just the direct cost of it. It also very much includes the cost of corruption, if I may say so, the cost of the leakage or the procurement. So mobilizing multiple providers for each goal can actually generate incentives for players to be cooperative and work towards a common national strategy. And that is, to us, the cornerstone of what we are talking about and why we are saying this is cost effective redundancy. And that's not a contradiction in terms. Think about it like you're building a table which is supposed to withstand an earthquake, or is supposed to be durable. Let's say not withstand an earthquake, but you want to build a table that's durable and can stand on its four legs, and you use inferior ply. And when an earthquake comes, it collapses. But if you build it with slightly better material, and when an earthquake comes along, which is what the pandemic almost feels like, the shocks just don't stop coming, the table is actually able to survive and stand. And so in the long run, or even in the short to medium term, in our response to the pandemic, it's actually a very cost-effective way of looking at it, scaling up. May I have the next slide, please? Yeah, so this is just visually mapping out what I've just talked about. You can see it's essentially you identify potentially feasible networks. If you can see this close enough, I possibly can't, you'll have to strain a little bit. You assign catalyst organizations, the coordination mechanism, and most importantly, identify the redundancies. That's when you identify the most cost-effective arrangement, and simultaneously you start scaling up. And this diagram, for those of you who are interested, is available in a World Development a piece that's just come out. It's not an article, but it's a letter that the World Development published, and it's available there. It really encapsulates the sort of adaptive integrated scaling mechanism that we're talking about in our framework. Next slide, please. And I'll quickly end. I know that we don't have time. I'm probably running a little over time. But yes, so this gives you an idea of the conventional delivery system. I've graded out because it's conventional. There's finance, which is the donor or the Ministry of Finance or the Ministry of Health. The response and coordination functions are across various ministries and line agencies, and the agencies delivering treatment are also very, very linked to the central government or the relevant line ministry. And I've said this before and I'll repeat this, but the chief constraint in this, in terms of delivering the scale that's required and the effective response that's required, is the capacity constraint and the governance constraints. It's just not possible for something that's so hierarchical and has so many constraints to scale up and deliver. It's not fit for purpose in that sense. It has to be complemented. This is not about bypassing the conventional healthcare system. There is absolutely no way in fragile contexts that you cannot work with whatever formal institutions of the state, but it's about complementing and it's about increasing the scale. Next slide, please. And this looks more closely at what an adaptive and a horizontal sort of matrix network might look like. So you still have the same functions. You still have the financing function, the very, very important coordination function, the delivery function. And then we also have something called treatment components. It's not just about, what are we delivering? It has to be broken down into very specific treatment components. So you have a treatment component at the community level. This is where social discipline might come into play, and we've done some work, or certainly are aware of some work happening in Dhaka and in areas like Dharavi in Bombay, in India. Dharavi is possibly the second largest slum in Asia. And in at least the initial infection wave in India, in Bombay, which was one of the hardest hit urban areas in the country, they actually managed to control a lot of the infection in Dharavi precisely through this kind of a scaled up approach. It wasn't something that was planned, but it was something that was much more intuitive. It brought in community workers. It brought in local doctors who had private practices and had generations long relationships with residents of the slum. It had local religious leaders. It had NGOs who were supplying food during quarantine. So in one sense, it was a sort of kernel for the idea that we are talking about here. So yes, the treatment component could be at the community level. It could be home care, which we think should become increasingly important because this pandemic isn't going to leave us in some time. And even if there is an effective vaccine, by the time it reaches all our developing and fragile contexts, it's not going to be sometime very soon. So home care should start becoming more and more important. You, of course, have primary care, and then there is the behavior response. So what would an alternative mechanism look like? Now, if you possibly looked at the black line that I'm talking about, there's financing coming from the central government. It might be given to a local NGO. The local NGO works with medical students in the local university, local medical university. This is to design some kind of home care protocol. And the home care protocol might need that you actually, for people to actually want to stay home, for people to be comfortable to stay home, you might need to deliver food, essentials, and medicines, for which you actually need to link up with the local transport agency. And you will see that there is another black line which leads up and joins together with working with the local medical students for home care. So that's an example. The red line is another similar example. You use community organizations and smaller NGOs to work with work in terms of behavior response, which needs some kind of community orientation. So these are just ideas. I'm not a healthcare expert. This is something that we kind of worked through with our thought through looking at the experience of the pandemic in Nepal and Bangladesh. For us, it was important to put the idea out there that scale is important because time is of the essence. Scale does not mean that you're adding extra cost. It actually means this is being cost effective. And we're also talking about an adaptive program that allows you to scale up or wind down as is required. What is extremely important is the role of the coordination agencies, which could be the catalyst organizations that we've listed here, obviously the donors. And we think that the emergency of a pandemic gives us the kind of, not us, but gives these organizations on the ground the kind of incentive to come together, which otherwise might have been captured by various kinds of rent seekers. And why this gives us at least a short to medium term window to address the sort of conditions created by the pandemic. And, if you're lucky, if some of these delivery mechanisms actually stick, it might, in the long term, actually help in progressing the healthcare system better by having some of these as permanent features of the healthcare system. So I'm going to stop here and hope that you have some questions for me. Thank you. Thank you very much.
Pallavi, that was wonderful. Thank you very much. This is a very elegant presentation of some concepts and ideas that we've been talking about within this working group for the last couple of years, with an emphasis on the idea that scaling should really be outcomes focused, not focused on a particular project or particular intervention, but how do we actually create a network focused on outcomes, coordinated across multiple types of implementing partners, government agencies, financing investors and institutions, such that we can move collectively towards an outcome in a way that helps us find the critical path, find a path that is the most effective, but also that builds resilience into this. And so the points that you incorporate into this on building redundancy as part of the cost effective and the overall effectiveness of the program, I think really resonates. So thank you very much for the presentation. And I'll open it up to comments. Alistair, I think you started a trail in the chat, but I can invite you to actually make the points verbally if easier. So if you'd like to make a comment or pose a question, please raise your hand with the button and then we'll get to you. Can we have Alistair's mic unmuted, please? And then Larry will come to you next.
Sorry, I need to unmute my own mic. No, thanks very much, Pallavi, for I thought a really fascinating and thought-provoking presentation. I mean, this was really excellent, and I like the phrase "cost-effective redundancy." That's something I really take away from this. And I think what you said resonates a lot from my own experience in Afghanistan. And I think dealing with fragility generally, people are under a lot of pressure to generate results. And indeed, when we start looking about conflict prevention, has a lot of parallels with dealing with the COVID crisis and the possibility for learning from our response from this crisis to think about more how we can institutionalize the prevention of violent conflict. I'd make several points. I mean, why this resonated with me, I think, is first building on what's there rather than trying to create new institutions or organizations from scratch. And I think that's really important in a crisis situation. I think the other thing that I think you came out quite clearly, which again links with my own experience, is this whole problem of taking collective action, particularly in societies which are quite individualistic. And as I've spent half of this year in New Zealand and half in the United States, I really see these issues very, very starkly. But you mentioned Bangladesh, and I mean, when I was doing rural electrification in Bangladesh, we found that rural society can take community collective action, and if you go to the community level, you can often solve problems that are impossible to solve at the national level because of the dynamics of society. I think one point I would make is on procurement, and again, that's been a huge challenge in the World Bank. And in the case of the health sector in Afghanistan, what we decided to do was essentially, there were NGOs providing health services all over the country, and to have a system of franchises that they had to bid for. So as well as, so it was a very simple bidding. And from my infrastructure experience, you can simplify the procurement for a massive power station just by going out to bid on the price of electricity, so many cents per kilowatt hour. It's as simple as all that. Whereas getting into all the details of the costs and things, you've got massive opportunities for corruption. And I think it is possible to have fairly rapid procurement, even in a crisis situation, perhaps not as crisis as COVID, if you're procuring the right things. And I would argue it's outputs, outcomes, if you can construct it that way. And there's a lot of lessons from infrastructure procurement on how to do that. The other big point I'd make is this issue, two more points. One is this issue of sustainability, and there's a whole history of temporary measures becoming permanent. Now, this actually may be a way of actually coming up with the kind of sensible organization of the health sector in any case, but it may be worth having that in the back of our minds going forward, because you look at the global humanitarian system, which Susanna was being critical of. I mean, that in a sense came from response to crises which required rapid action, although the crises have tended to become prolonged, and it's become the kind of default set of arrangements. So I think there's that issue of sustainability. And the last one is, at the end of the day, there needs to be some kind of evaluation, screening. Which of these multiple providers work best? Which are the ones we want to nurture for the future? And which, in a way, are shall I say, failures? And being able to penalize the failures, to stop doing things in international development, is extraordinarily difficult. Let me stop there.
Do you want me to respond to any of this, or because this was really a series of very complimentary comments, because I agree.
Let's perhaps, I suggest, take Larry's comments as well, and then you can take the look. Yeah.
Sure.
Can we please unmute Larry?
Pallavi, I too enjoyed the presentation very much. Thanks so much for it. My question comment sort of speaks to something that you mentioned, but then slid over fairly quickly, I think, which is the issue of coordination. And for me, coordination is no easier than hierarchy. In fact, in some ways it's harder than hierarchy, because hierarchy we're kind of hardwired for, and systems tend to know what to do with hierarchy, and they tend to be less good at being systematic about anything horizontal. And even if it's something like letting 1,000 flowers bloom, that's not kind of what's implicit in what you're saying. There's a little bit more orchestration than that implied in what you're talking about, even if it's through a wide number of delivery points on this. And Jonathan and I have debated, discussed, and struggled with this issue of coordination, and looked at a number of different models in different countries, depending on just in what way they're fragile. Because some places are fragile, but still have a basic governmental structure that functions, and others it's broken down altogether. Pick a Somalia, for example. So when you start thinking about that collaboration structure, I think something this group could do, and something I would be glad to hear from you on now, is just how we can push the envelope on that. Because I think the farther we can go in helping people think about possible approaches to that problem, the more approachable this horizontal strategy and redundancy becomes, without simply saying we're giving up the idea of doing this in a systematic way at all.
Thanks, Larry. Over to you, Pallavi.
Thank you, Larry. Absolutely bang on. It might have been completely psychological and subconscious. I skipped over it simply because it's difficult to answer, but you're right. That is essentially the nub of things. And if you notice in the matrix that I presented, that's part of our framework, we also have something called catalyst organization in that same coordination pillar. And I think one way of going around that, and I'm sure this has been tried, might not work in all contexts, and but in some contexts, it might actually be possible to choose a catalyst organization which is delinked from your, the standard coordination agency, whether it's the Ministry of Health or any other large NGO maybe in a refugee camp situation, but identifying a large enough catalyst organization with enough legitimacy and buy-in, which can, for at least the next year and a half, be the kind of entity which coordinates among the different horizontal agencies, has some kind of M&E oversight, something that Alistair also talked about. And I completely agree with the monitoring of what doesn't work is as important. So coordination will certainly make or break this, but I think the idea was also to start building a conversation around moving beyond the silo of the public healthcare system. That doesn't solve the problem of coordination, but this was much more an idea using the framework to get that conversation started, that we actually need more than what is available to us within the public health system or the centralized government formal institutional system. So the Catalyst organization was placed there with an idea to really tease out that coordination is important, and they are invested with the functions of it. It's going to work out differently in different contexts. It would be more successful in some, it would be less successful in others, but we need to find some way of finding that particular coordination agency. Otherwise, this framework isn't going to be successful, and we're absolutely clear about that. And the next line of research, when it becomes operational, this is still a framework, but this has to be operationalized. And I think the task of operationalizing is really how you identify that coordination mechanism and work with the Catalyst organization. The point very well taken, Larry. Thank you.
And do you want to respond to any of Alistair's points?
Actually, you know what? I agree with all of them. Outcomes-based, not input-based. I mean, in the electricity sector, it is still possible to game. I mean, I do a lot of work in Nigeria, and you can put an output-based benchmark out there, and you can still fail, and the country will still not produce enough electricity. But I think in a pandemic kind of situation where you need an emergency response, you can actually find, given the sort of public healthcare impetus behind it, you can actually find a lot of organizations which will respond to the output-based compulsion. That could certainly work. The sustainability of interventions for us, and I did kind of, I think, mention, though it was in passing, for us, one of the long-term aims would also be whether this kind of, an iterative system can actually be cemented into the public healthcare delivery system. And therefore, then it becomes more sustainable. Some of the interventions might actually be very good for communicable diseases that are still very important in African and South Asian contexts. And the monitoring of what works is extremely, extremely important, rather more of what doesn't work, because these are also very sort of rent-thick areas of operation. Public healthcare has always been extremely rent-thick. So the monitoring is a very critical part of it, and links back to the point of the Catalyst agency. Can that be given the monitoring function?
Very good. If anybody would like to pose a question or make a comment, please raise your digital hand and we'll get to you. Two comments in the meantime while we're waiting. One is that I see a lot of application of this work in emerging approaches for resilience outside the traditional sector of food security. So USAID, for example, has now launched a lot of new work on resilient health systems in fragile states. And it's, as you say, Pallavi, looking at how do you bridge the formal and the informal system together? How do you bring a much wider set of partners together around this? So I see a lot of application for this, and I'll actually come to you separately to talk about something that we're planning with USAID on this front. The other thing I think that I observe is that this is sort of the long-awaited sort of next generation of thinking following on work that, for example, the basic package on health services in Afghanistan, which had some precursors in Cambodia and Bosnia before that, but this attempt to build catalyst organizations and support around the Ministry of Health for a very large network of partners to go off and do primary healthcare in very different places in Afghanistan. So some of them were conflict affected, dealing with insurgency. Others were just drought affected, dealing with displacements. And they actually managed this basic package to reach its MDG goal of cutting infant and maternal mortality in half by 2015. So it's a really interesting model. Larry and I, in some of the work we've done, have tried to suggest or recommend how we can incorporate resilience types of work into something this big, as well as trying to change the patterns of cooperation and inclusion within that process. So trying to get some of the root causes of risk. But I think what you've given us now is a really rich framework from which to think about this, and rooted in some recent experiences around Bangladesh and Nepal. So we're really pleased that you could share this with us. Rob, please. And I actually mentioned too that Rob had worked on the basic package during time in Afghanistan, and Alistair was the head of fragility for the World Bank for a number of years, and was actually the country director in Afghanistan during that time. So we've got some veterans of that program here. Rob, over to you.
No, Pallavi, thank you. Excellent presentation, and really nicely summarizes a lot of the thinking. And my questions are as much just to sort of push you a little bit to expand, because I know that we specifically asked you to speak about the COVID case, and that's obviously what's front of lots of people's minds. And I guess I wondered whether, as you've been pulling together some of this work and think about, for want of a better way of describing it, how much matters the sector or that you're working on. By which I mean, I think the health example is marvelous and it's topical right now in COVID. And I think, just as Alistair and Jonathan have said, this model of it's not quite let 1,000 flowers bloom, but it's to make sure that you use whatever redundancies, whatever actors are available without as much worry about redundancy, but more interest in coverage in the health sector. That really works nicely. I did a paper when I was working on Afghanistan that sort of looked at the contrast between how the health sector operated in Afghanistan and the way the education sector operated. And what was, and Alistair may be able to speak to this more poignantly because I think he was probably in the room where it happened. But what was so interesting is this notion of setting up contractual models to allow healthcare operators to achieve results in certain locales according to a contract. Importantly, and this gets a little bit to Larry's question about coordination versus hierarchy, there's a contracting, a principal agent relationship that's being set up between government and healthcare provider that I think is an important aspect to keep in mind. I'm not saying it has to be deeply hierarchical, but there does need to be some contracting going on. Any event, that contracting in health was an idea the government took on without trouble. They did not take it on in education. And part of that is, and there were plenty of education providers, but part of what is obviously different in the education sphere when working in fragility is that a big role of the government, of the sovereign, is in some ways to try to make sure that everyone is educated with the same history, language. You know, there's more nation building and subjectivity of nation building in education than there is in health. I wonder if you've thought a little bit about the way these different models might work in different sectors. Over to you. Oh, and one other thing, the food security sector is one that I work with a lot in the Horn. And again, how much could this work potentially in the food security sector? Just to think a little bit about elaborations on your talk. Over.
We really focused our attention on the healthcare sector because that's where we were working. But now that you talk about it, I really don't think that the structure of the education sector is also set up in a manner that would find this framework extremely useful, because there are not as many discrete moving parts in the education sector. It's a lot more centralized, it's more lumpy. Investments in education tend to be more lumpy, whereas in health, you know, there's a bit of both. You can have, yes, of course, your tertiary hospital, your primary healthcare center, but there are also other satellites within that whole thing, because we're also talking behavioral response. And this is much more, since we're talking behavior here, healthcare is much more suited to, you know, bringing in aspects of behavior and that kind of enforcement than education. There is a limit. There is an element of behavior, of course, but not as pronounced as we have in healthcare. And in education, you're also talking about some fairly, I would imagine, and I'm really thinking, you know, I would have said on my feet, but I'm sitting down, but I'm really thinking as I'm sitting down now. The social norms in education are also extremely different and it's fairly more difficult to dislodge, because the incentive structure of the social norm around education is very different from the incentive structure around the social norm in health, where it could be more easy to change because you're talking about something where you're talking about mortality and death and you know, handicaps, etc. So it might be easier to address. In education, it's not. So the structure of the two sectors is very different. Food, I certainly can see from my experience in Nigeria, for instance. You know, when you're talking about food security, you're not just talking about seeds and farmers. You could be talking about fertilizers. You could then be linking it right back to, let's say, indigenization of the manufacturing process for fertilizers. There's a whole ecosystem there which would actually work very well and would work with this kind of a framework. I wouldn't quite think education would fit the kind of framework that we are talking about. So yes, there are definite sectoral implications here when talking about this framework. Totally. Now that I'm thinking about it. Thanks, Rob.
Pallavi, Alistair asks in the comments how you see cash transfers as a way of potentially getting around some of the corruption and capacity constraints and potentially helping to bridge towards more permanent social protection systems, safety nets, etc.
Okay, I'll do the typical academic thing here, Alistair, and plug a paper that Mushtaq and I have actually written on this. It's on the ACE website. It's on digital identities and not so much on cash transfers, but digital identities and social protection. And like good academics, we have a 2x2 framework on it. But and the framework essentially does say that what matters is the relative holding power, because we come from a political settlements background, is the relative holding power of somebody who is actually implementing that digital social protection system. Now, you're talking about cash transfers, of course, you're not talking about digital, and cash transfers definitely work. When you're talking about an emergency response, when you're talking about shocks, cash transfers are a very, very good way of smoothing the shock to the system. There's absolutely no doubt about that. And countries which, for instance, Africa has actually done very well, and I'm sure a lot of you, on this panel would have already known about that, but close to about 40 odd African countries have already tried cash transfer-based social protection systems, and it has gone a fairly long way in terms of buttressing the shock from the lockdown. In Africa, it's not been so much the health consequence, it's been the economic consequence of the lockdown. So that has certainly definitely worked. And there will always be ways to game the system. Nothing can be completely 100% leak-proof, especially in the context that we are talking about. It's always possible to get a fingerprint, a thumbprint, or even get a biometric card of somebody and claim on her or his behalf. So it's not going to be as foolproof if it can go directly into a bank, like a direct benefit transfer. That can actually work very well. Some countries like Kenya, even Nigeria and Ghana have made some progress in that. So absolutely, they can work. If they go straight into bank accounts, they work even better. Digital identities can be a bit of a problem, but I'm not going into that right now. I hope that answers your question.
Thank you very much, Pallavi. We'll be sure to add the digital identities paper as well to the Senate that we'll do to the group afterwards. And thank you once again. We really appreciated the time, the presentation, the insights. It's been great.